hand over to Paul.
Thanks, Ravinda. Can you hear me okay?
Yeah, I can hear
That's
you.
great. Okay. Good morning, everyone. So lovely to be invited along to talk a little bit today about one part of this study. And I've sort of tried to identify it on this sort of schematic. So the overall SepTiC confederation of trials really is looking at various interventions, as you know, and I'm going to focus on the diagnostic study in the first part of today's presentation. So myself, my name's Paul Dark. I'm Professor of Critical Care in Greater Manchester and at the University of Manchester. And my own centre in the trial is the Northern Care Alliance at Salford Royal, and we've been recruiting patients there. So I can talk, if it's helpful, about how we sort of set things up there. And I don't know if Emma Parkin might be on. She's our advanced critical care practitioner that's running the trial at Salford. And if Emma's here, obviously it might be useful to bring Emma in as well. So, and I help run this part of the diagnostic study with Professor Ronan McMullen from Belfast, who complements the team because he has a real expertise in infectious disease, microbiology, and diagnostic innovation. So it's lovely to have Ronan involved in this with us as a trial team. And we sort of set this intervention up based on our previous experience, not only with the PCR rapid pathogen diagnostic, and we've done quite a lot of observational studies with NIHR funding in the past to prove that they do what they say on the can. But we also discovered that the measurement of PCT, procalcitonin, produces a piece of powerful information in combination. So both optimizing antibiotics based on the pathogen result from the PCR pathogen result, which is quite novel, and combining that with an understanding of levels and patterns of response with procalcitonin. And we've kind of shown that in the past, but it's never really been trialed fully together. And this is the first time this has been done in the world. So we're very excited that you're recruiting patients to this. But it has raised one or two questions specifically around procalcitonin. And some of you may know that we've led from Manchester the ADAPT sepsis study over the last 7 or 8 years, actually as a collaboration with Imperial and Belfast with Ronan. So a wide investigation and a randomized controlled trial around the use of procalcitonin on its own to work out whether it's safe to stop antibiotics based on a falling or low level. And that all of that work is now completed. Thank you for those on the line that have contributed to that study. We couldn't have done it without you. And I thought Tony, David, and the team at Imperial thought it might be useful if I just briefly summarize the results of that, perhaps to build as much confidence as possible in the use of PCT in our diagnostic study, because I think it does have greater opportunity than just on its own. So bringing the two diagnostics together, we hope and we believe is very important. So, which is why it's being tested in the SepTiC trial. So next slide, please, Ravinda. So let's go and just recap about the ADAPT sepsis trial. So this was a 3-arm randomized controlled trial looking at standard antibiotic use in sepsis. And funnily enough, this trial used the same inclusion criteria as we're using for the SepTiC trial. So I think, the patients that we recruited into the ADAPT sepsis are the same patients. So this was quite a big trial comparing daily CRP as decision support when to stop antibiotics with daily PCT and against the standard of care where neither of those were used. And this was a unusual trial in that the interventions were blinded. So investigators didn't know the source of information they were being given. And we gave decision support advice based on low or falling levels of CRP and PCT. Now, that was published last year, presented about a year ago at the Critical Care Review meeting down under, and the JAMA paper, if you're interested, is there. And if you use your phones and go to the QR code, that will take you straight to the open access paper if you're interested. But the conclusion of that trial, I mean, perhaps isn't surprising, but the way we set the trial up, we weren't sure whether any of these protocols were going to provide advantage on top of standard care. But really interesting that PC did, that in a wide range of critically ill hospitalized medical and surgical adult patients in the NHS, there was a significant safe reduction in the total antibiotic days using the PCT protocol. And we didn't see that with CRP. And in fact, there might have even been a potential for a harm signal in the CRP. So that gives us more confidence in the use of PCT, I think, that it is safe in this pathway. But of course, this was an unusual trial because the interventions were blinded. And we did that to try and get the best evidence for the use of decision support in the sepsis care pathway with one of these markers. So let's go on to the next slide, Ravinder. So what we subsequently did, and this was published just at the beginning of this year, although it's titled as a rapid review, these things take quite a bit of time, but it was using a Cochrane group based in Manchester, as part of our NIHR Applied Research Collaborative. So they independently looked at all the studies using PCT in randomized clinical trials over the last 10 years, looking at whether they were effective in reducing antibiotic duration and whether they were safe. And again, there's a QR code if you're interested it's an open access paper. You can have a look at it if you're interested. But I'm going to show 2 slides of the summary of what we found in 19 trials over 10 years with 6,382 patients as part of these trials. And you can see the trials listed there. And what we're showing here in the green bars is the potential average saving for each of these trials that was measured. And so 0 is no days saving, -5 is 5 days saving of antibiotic use, and obviously +5 is, well, it increases the use of antibiotics. And you can see that overall, there's an average 2-day saving using serial PCT in the pathway, and that's doesn't overlap 0. And you can see that black a diamond at the bottom there, so a very tight confidence interval. So very confident that this could save between 1.4 and 2.6 days of antibiotics based on your current care, whatever that is. So very reassuring that across all trials, and the other trials were open label trials, and ours was a concealed trial. So a lot of quality in that. There's a bit of heterogeneity, but quite exciting that overall there's a clear saving. So next slide, please, Ravinder. So one of the questions is, it's all very well saving antibiotics with the measurement of PCT, but is it safe? And most trials use mortality, usually 28 to 30-day mortality, to work out if this approach is safe. Patients, actually, when you ask patients, they quite like mortality as a robust figure. They don't want to feel that they're being exposed to more risk by reducing antibiotics using PCT. And this is all of the mortality data reported in those trials that I've just mentioned. And you can see there is some variation, but overall, look at the diamond at the bottom. It's very clear that we have shown safety, that there is no difference in mortality between standard care and the use of PCT. And in fact, there is a tendency towards a 5% reduction of risk of mortality, but it's not significant. But there is a tendency towards improved mortality, which seems a bit odd that reducing antibiotics by a couple of days using daily PCT results in a mortality saving. I mean, that's yet to be explained in studies, but it could be an important effect around using biomarker decision support in this pathway. So next slide, please, Ravinder. So what we then went on to do with all of that information is ask the question, if you were to introduce PCT, if you're not using it already in the sepsis care pathway, would it be cost effective? And there's again a QR code there, and this paper was published just before Christmas. And again, it's in open access. These calculations and modelling was performed by Professor Matt Stevenson at Sheffield, who leads a lot of nice appraisals on healthcare interventions and particularly diagnostic interventions. He's very familiar with precision medicine, particularly with oncology. So it's quite an important result list that Matt's calculations show that this is a highly cost-effective intervention. So the way NICE look at this approach is to work out how much would it cost to produce one quality adjusted life year. And with Matt's modelling and calculations, comes out at about £2,000. You'll see in the paper, it was a European paper, and we've put that in euros, obviously, for the European audience. But here we've shown it in pounds sterling. Now, you probably know that NICE thresholds for introducing technologies means that a QALY has to come below about £30,000. So there's not much in ICU, or indeed many parts of healthcare, that you'll get this kind of improvement in quality adjusted life year for such a low cost to services. So that obviously isn't a cost to ICU, but the broader costs. So and we've got a reasonable to good sense of the probability associated with that. So 73% doesn't sound hugely probable in the world of clinical medicine, but in the world of health economics, a 73% certainty this is cost effective is a very high level of certainty about how cost effective this is if it was introduced routinely into the NHS. So you can have a look at that. This body of evidence was presented 2 weeks ago to NICE, so it's all been sent to them as part of their prioritised area of improving guidances for sepsis care. It's one of 3 to 5 areas that have been prioritised by NICE because it links into new Department of Health priorities, and sepsis is in sepsis care is in one of those priorities. So you can see that the kind of research you're involved in and what we're discussing here is very significant priority for the government and for NICE. So there will be a consideration for this, and obviously I am not involved in that as an investigator in these trials, but the NIHR will be representing the public spend in this arena to help guide future NICE recommendations. So I think what is important in the SepTiC trial is that we're using PCT at the point of randomization of the patient. So that's the baseline measurement. And then we're asking for a second PCT within 3 days. And that concords with the kind of evidence that exists in the ADAPT sepsis trial and others, that those are sort of pragmatic ways to use this. The levels that we set in the SepTiC trial are that if any of those readings are less than 0.5 micrograms per litre, and there is no evidence from the PCR or other microbiology evidence that you're looking at, then that's a very, very strong signal to consider stopping antibiotics, because you probably are not looking at a bacterial cause of illness for the patient that you're looking at. And it drives a question about thinking very carefully within the clinical team about what on earth is causing the illness that you're looking at. So what we call the differential diagnosis. So that's a very important opportunity in the trial. Also, if the second reading falls 80% from the first reading, that also gives you a similar kind of piece of information. And that concords completely with this international database. So I think, the Imperial team were keen that we shared that with you, because it's really grown the strength of evidence around what we're trying to do in this trial, that PCT works. But what we're testing here about optimizing the approach of antibiotics with patients using the pathogen rapid response, that allows you to make sort of quite complex decisions with your microbiologists and care team about how best to treat this patient. Is the patient on the right antibiotics for the pathogen if it's discovered? If there's no pathogen discovered and PCT is low or falling as we've described, that's a very strong argument for considering stopping antibiotics. So I kind of leave it there. I'm very happy to take any questions on any of that, Ravinder.
Thanks, Paul. We'll just wait and see if anyone has any questions at this point.
I mean, I might just reflect on how Emma Parkin has set up the trial at Salford. We've come in a later wave, I think, Ravinder. We didn't set up immediately because we were completing ADAPT sepsis. And so we're, obviously we get the PCT, the PCR rapid pathogen result from the Imperial labs, which is fantastic. So we don't have to run that or pay for it. So that's absolutely fabulous. Our contribution in service to this is to measure the two PCT, one at randomization and the PCT measurement within the first 3 days. Now that's that is an assay that is available in our trust. And interestingly, our acute medics use it quite a bit in a non-evidence-based way and outside of trials. So there's been quite a bit of support in our trust that we're actually, we're looking at implementing PCT at the moment in intensive care based on the ADAPT results, because that is probably now considered a standard of care. And we look forward to NICE and the international guidance is coming subsequently. But quite a lot of the hospitals certainly in Manchester, are now moving to implementation of daily PCT measurement. But the labs are sort of, from our perspective, the occasional use of PCT in ICU in the SepTiC trial is much appreciated, because, for the number of patients involved and the number of measurements we're doing, we're exposing that test, which is now a standard of care, to an additional indication that could be even more exciting. So that's how we've handled it in Salford, Ravinder.
Thanks, Paul. It's really helpful to hear how it's going at Salford. I feel that gives the other sites a bit of insight as well. Just wait another moment to see if anyone has any questions. Please feel free to pop them in the chat as well.
Yeah, and we've got a recording of this. I can see the recording on, so really happy that you share this information with the rest of the team. Please rerun it, and also look at the evidence that I've shown today. And we can tackle any questions through the trial team, myself, David, Ronan, Tony, as needed.
Claire, I think you got your hand up.
Fantastic. Yeah, great presentation, Paul. Thank you. and really positive to see that you've forwarded the results to NICE. So looking forward to their response there. From here, is there a drive towards antibiotic resistance, and how you manage to measure that to back this up further?
So Claire, that's a fantastic question, because the cost effectiveness that we've done here and all the clinical effectiveness was not considering the impact on AMR, because you might guess that if we're reducing antibiotic burden in patients, that there might be some signal around improvement in AMR pressures, whether it be in the individual patient or on the unit or subsequently. Those are really complicated and difficult studies to do. And we weren't funded in the ADAPT Sepsis to do that. I think the first question Department of Health and NHR wanted to know is, does this approach make a difference to how we behave with antibiotics in the ICU? Clearly it does. And does it provide advantage to patients and services at this cost-effective level? And clearly it does. But I think this question of, if we behave better with antibiotics in ICU, do we see impact on AMR downstream, is a really important question, and something that I think funders are going to be more invested in the future. I think this was looked at a little bit in the Bling set of studies around infusions versus continuous infusions versus intermittent antibiotic doses in ICU. And also in the SepTiC's set of studies that Imperial were involved in as well, in leading around selective gut decontamination, because there are all sorts of interesting questions about AMR pressures. And I think they were able to give us some reassurance, certainly around the SepTiC question, of making sure that we weren't worsening AMR in this in that intervention. So I think we need to look at those studies and the way they did that, and think about in future studies whether we can embed those kind of approaches, in future large-scale randomized controlled trials. But sites will hate us if we get you to do a whole load of stuff, swabbing patients multiply, taking stool samples, etc. But I think it is something that we need to invest more time and effort in, because it could show us that these approaches are even more impactful than we think in terms of public health. I hope that kind of sort of partially addresses your question, Claire. If you look at the JAMA paper, we were asked that question actually in a letter from a group at Harvard, and you can have a look at our reply. It was pretty much what I've just said, which is we completely agree with you. We need to spend more energy at addressing that. We assume that it's beneficial to patients to reduce, and society to reduce, antibiotic burden. And remember that these are antibiotics that we usually reserve for difficult to treat infections, not the kind of antibiotics you would receive in the community. So I think these are really important questions that we need to consider in the future.
Thank you, Paul. That's great.
Thanks, Claire.
In that case, I think we might just move along with the study update. Yeah, but
please do.
If there are any other questions for Paul, please do pop them in the chat as well. So just our regular study updates and reminders. We now have 35 sites open to recruitment across the UK. So recently, Cleveland Clinic London have joined us, and there are over 570 participants randomized to the trial overall, and that includes over 100 participants randomized to the GM-CSF intervention. So thanks everybody for all your hard work with recruitment lately, especially in the new year. And you'll have seen from the newsletter that was circulated earlier this week that we've just updated 2 documents. So one is our sample manual, And this is just kind of a reminder to supersede the previous one. Make sure you're using this sample manual. And the reason behind the change is just 2 small changes to the sample shipping form, also sent with a newsletter. So we've just added some clarification at the top of the sample shipping form here, that the name included on the form should be a name of a staff member. And the only patient details that we are including on the form are just the trial ID and their month and year of birth only. So just some actions for you to take are to make sure that you localize the new version 2 of the form and ensure that's saved in your ISF or electronic ISF. And just a reminder not to send any identifiable information to our team, septic@imperial.ac.uk, but please do ensure all the fields are completed when you send the form. So the email addresses especially are used to email the PCR results to your site. So if the lab are struggling to identify the patient, then it may delay your PCR results. Just another reminder that we had in some of our previous webinars. So the EQ5D telephone questionnaire, this is the only questionnaire we ask for you to complete at the 6-month follow-up. We ask for you to print off the EQ5D telephone questionnaire and complete on paper, as that is the version that includes the telephone script for you to read out with the participant during the conversation. And then that form will also act as the source data, which you will then enter the results onto Open Clinica. The completed questionnaires should then be filed in your ISF. So the version we have on Open Clinica just records the answers to the EQ5D, but it doesn't include the full telephone script. And as it's a validated questionnaire, you just need to ensure that it's being conducted in full. And then some other documents that were circulated in December with the protocol amendment. So as we amended some wording on the inclusion-exclusion criteria, we amended the eligibility form in line with that. So it's just to make sure that everybody's using the version 3 and that this is completed for every patient randomized into the trial. As SepTiC is a CTIMP, this needs to be completed and signed by a clinician. And then associated with that updated eligibility form are the eligibility slides. Again, updated in line with our recent protocol amendment. And then just something we wanted to begin letting sites know about. So you may have already had some correspondence from your local R&D teams, but just something to make you aware that the ICH GCP guidelines are going to be updated and will be used from the 28th of April 2026. And in preparation for this, all staff working on clinical trials will need to renew their GCP training to the most recent regulations. So we're just including a reminder, even if your GCP training is not due, you will need to complete the new training in accordance with the new guidelines by the 27th of April to prepare for the change. And we'll include some more reminders in our future webinars as well. And then that's it. That's just kind of a reminder for our next webinar. And what we'll do is we can stop the recording